Hello, I'm Dr. Milica Vukićević, a Harvey scholar at Brigham and Women's Hospital, the MGB campus in Boston, bringing you heart failure minutes. Today, I'm joined by Professor Greg Lewis to focus on a topic that continues to intrigue and challenge us: iron deficiency in heart failure. We've learned that oral iron doesn't work in heart failure, likely due to hepcidin-mediated blockade of intestinal absorption, and that IV iron, while improving heart failure worsening events, has not yet demonstrated a survival benefit. Let's dive deeper into what this means for clinical practice and future research. So first, let's point defining iron deficiency. Professor Lewis, traditional metrics of ferritin, which reflects storage of iron, and transferrin saturation, which is more directed towards tissue utilization, were largely borrowed from hematology, but current definitions may not fully capture tissue iron bioavailability in chronic heart failure. How should the iron deficiency be best defined today, especially in the context of GDMT, such as SGLT2 inhibitors, that may alter iron indices?
Yes, thank you for the question. I've had a long-standing interest in iron metabolism in heart failure, and as you pointed out, oral iron preparations are ineffective in treating iron deficiency in heart failure. And with the recent HEART-FID trial, which was the largest trial of intravenous iron repletion done to date, we had the opportunity to look carefully at the question you just posed, which is, how should we be defining iron deficiency in order to identify patients that are most likely to derive benefit from repletion of iron? And historically, both from the hematology literature as well as from the renal literature, we've used ferritin as an indicator of iron deficiency. And in fact, the most common reason for patients to meet entry criteria for the large HEART-FID trial was a low ferritin level. What we've found in more recent studies is that the ferritin levels may not be an accurate reflection of iron bioavailability in patients with heart failure. It will be higher in pro-inflammatory states, and the ferritin itself has very little to do with iron. Ferritin is a nanocage that is a storage vessel for iron inside of cells. And so when we measure ferritin levels in the extracellular space, we're really capturing the propensity for that ferritin to exit from cells. And that can be driven by pro-inflammatory states, that can be driven back in the height of COVID, we were measuring ferritin levels as an indicator of disease severity, but not as an indicator of whether or not patients would benefit from us augmenting their amount of iron exposure. So we've started to rethink, where should our focus be? And the transferrin saturation levels less than 20% are quite concordant. They relate to outcomes in patients: lower transferrin saturation, worse outcomes. They relate to functional capacity, lower transferrin saturations, lower 6-minute walk distances, and lower hemoglobin levels. And when we look over time in the HEART-FID trial, we find that with iron repletion, improvements in transferrin saturation correlate with improvements in 6-minute walk distance, they correlate with improvements in hemoglobin levels, and they correlate with better outcomes. For ferritin, none of those things are true. There's no correlation with 6-minute walk distance. In fact, patients who had the lower ferritin levels actually walked further at baseline. So I think that this is an opportunity for us to begin to de-emphasize ferritin when we're thinking about patients with heart failure, and to again shift our attention more towards transferrin saturation and also towards the iron levels themselves.
Thank you very much for this explanation. It really means a lot to understand really what's happening when talking about iron. So we can also focus on evidence gaps and the next steps. So the aggregate data from IV iron trials suggest improvement in symptoms and functional capacity, and perhaps a reduction in heart failure hospitalizations, but no clear mortality signal. Where do you think the evidence gaps remain, and how are ongoing or planned studies trying to address them? Particularly in terms of trial duration, endpoints, or novel formulations that bypass hepcidin effects. Can we return to oral iron?
Thank you for the question. There's a lot to unpack there. So first, the current evidence. We have been fortunate to have a number of trials with intravenous iron repletion that have consistently demonstrated that with intravenous iron repletion, we're able to improve functional capacity in heart failure. Still a tremendous unmet need, and actually our 4 pillars of GDMT have modest, if any, significant improvements in functional capacity associated with them. If we look at beta blockers, ACE inhibitors, ARNIs, SGLT2 inhibitors, none of them significantly change exercise capacity in patients with heart failure reduced EF. Intravenous iron formulations do have benefits in the studies that have been done that specifically focused on functional endpoints. And so there's a functional capacity improvement. The studies that have been done for heart failure hospitalization or mortality have demonstrated that there is a significant trend towards improvement in outcomes, but none of those larger scale trials have actually met the primary endpoint with statistical significance. There's been a lot of near misses, and those near misses have resulted in meta-analyses that have shown that there's improvement in outcomes. But as you stated, we haven't seen a mortality benefit. And if we look at studies like the AFFIRM trial and the HEART-FID study, we did not meet our primary endpoints in those trials for reduction in heart failure hospitalization, mortality combined endpoints. So currently the ICONIC trial is launching in the US and elsewhere in order to look to see if we can use that new definition that I mentioned, which is focused exclusively on low transferrin saturation and no longer considers ferritin levels. And using a transferrin saturation less than 20%, we're going to see if the combined endpoint of heart failure hospitalizations and mortality is improved by the administration of ferric deoxymaltose, which can be given in high doses up to 2 grams at a time intravenously, and can be administered safely in patients with heart failure. But we are looking to fill that evidence gap to say that we have a statistically significant trial that meets its primary endpoint that can add to the encouraging functional capacity and trends towards improvement in outcomes that we've seen with the other intravenous iron trials to date.
Most of the pivotal iron studies have focused on HFrEF. But we are increasingly seeing iron deficiency across the broader heart failure spectrum. So how should clinicians approach iron repletion in HFpEF, where systemic inflammation and altered iron handling may play a different role? And do you see biologic possibility for benefit there?
Yes, thank you for the question. So you're absolutely right. The weight of evidence has really been in heart failure with reduced ejection fraction to date. That's where all the studies have been focused. There's one small study called FAIR-HFpEF that reported on 37 patients. It was designed to be a much larger study that demonstrated improvements in 6-minute walk distance in a heart failure preserved EF population that was treated with ferric carboxymaltose or placebo. But that was a very small sample size. It was incomplete ascertainment of the change in 6-minute walk test in terms of the patients that ended up being enrolled. So we're currently conducting a trial by the name of IronMet that seeks to understand a whole array of functional capacity endpoints and whether they differ between individuals who are treated with heart failure preserved ejection fraction and iron deficiency. Again, we're focused on the transferrin saturation definition as opposed to a ferritin-based definition of heart failure with iron deficiency. And we're going to determine whether or not patients that are treated with intravenous iron have improvements in measures such as peak oxygen uptake, 6-minute walk distance, an array of echocardiographic variables, as well as other submaximum exercise capacity measures. And that trial is actually nearing completion. It's a NIH-sponsored trial that we're conducting here at MGB. and we plan to complete enrollment over the course of the next 3 months. So that'll be reading out soon, and we're excited to see if we'll be able to add to the evidence base behind intravenous iron repletion in patients with heart failure preserved ejection fraction, because that remains an evidence gap at present.
Thank you very much, Professor Lewis, for your insights and leadership in defining the boundaries of this field. Our understanding of iron metabolism in heart failure is shifting from hemoglobin to one on cellular energetics, mitochondrial function, and inflammation. So the next generation of trials may hopefully finally connect these mechanistic pathways to clinical outcomes. This is Dr. Milica Vukićević signing off for now. Until next time.